until 2017. And that's specifically on the exchange. And if we truly want to move forward and bring this debate closer and empower the people, what we should do is we should have a debate in our state legislature about implementing the exchange. We should have a debate about expanding Medicaid. We shouldn't be sitting here waiting with a giant red stop sign that says we're not going to do anything until after we have an election. I think that's leaving too much to chance. And we have until November 16th to tell the federal government whether we will want to do our own health insurance exchange here in Wisconsin. If we don't do that, the very federal government that Representative Stone is afraid of taking over our health insurance system will do exactly that. There will be a federally operated exchange here in Wisconsin. So now is the time, between now and November 16th, we have a month and a half, where we could be having a healthy debate, as we are tonight, about what an exchange should look like in Wisconsin. And then next year, when Representative Stone and his colleagues go and do the budget, they should be talking about what a Medicaid expansion would look like in Wisconsin. The law gives states a free pass, essentially, to expand Medicaid up to 133% of poverty for all Wisconsinites. That's free federal money coming to us to give all of these people who are uninsured a free pass. It's a free pass. It's free money, money that we will leave on the table if we don't take that expansion. And if we don't, the numbers are 170,000 Wisconsinites, your fellow Wisconsinites, Representative Stone's constituents, our friends, the clients that we serve where I work at Community Advocates will remain uninsured, 170,000. That's a real number from Jonathan Gruber, who's an MIT economist who was commissioned by the Doyle administration to examine our insurance markets. And that report has essentially been endorsed by the Doyle administration and used by them. So we have an opportunity here to go after a state-specific policy that we can be debating and implementing right now. And that's something we should be doing. And I just want to say one other thing on the outcomes portion. In Medicare and in the bill, there's what's called I forget the exact name, it's the outcomes research.
Comparative effectiveness research.
Yeah, it's got 4 or 5 words that go all together there. And that's the very thing that those who are against the law have called the death panel. And it's the very thing that should be the thing examining what the outcomes are in Medicare and in other health insurance realms. Yet it's the thing that's being attacked the most and is sort of this mythical creature that lives out there that isn't going to do what the opponents say. So just one other thing on outcomes.
Okay, thank you. Okay, I'd like to open it up to the audience now, either for questions. I saw you had your hand up.
Thank you.
Now, either a question or a statement that you'd like to make, either one.
Right, couple of items. You know, in the dialogue that you had, it's very civil. Appreciate that, and I congratulate you on this format of summarizing the opponent's discussion. I was busy taking notes, so I really didn't summarize what you had to say.
And it makes sense to everybody else. I think that's what we want to know too.
There was some conversation regarding the waste in the system, but I hope somebody can address the issue of the administrative cost of insurance. A New England Journal of Medicine article that came approximately 15 years ago stated the administrative cost of private health insurance at 28%. In other words, 28 cents out of every dollar that is paid by premium is going towards administrative cost, whereas the administrative cost of Medicare is 1.5%. Very important difference. I hope you can address that issue. Also, in the administrative cost is the tremendous salaries and benefits that are given to high officials in the insurance companies. For example, why should the United Healthcare CEO receive $600 million in compensation in 1 year out of stock options and salaries? The other one I want to say is this, that health and wellness programs are very much part of the Affordable Care Act. It requires employers and insurers to come up with plans to promote wellness in the place of employment and also to employ techniques of prevention of disease. It puts a lot of money up front for primary care residency training for physicians and shifts the cost of residency training or investment in residency training from high-paying specialties, very narrow specialties, to primary care residency. if you don't know that there is a shortage of primary care doctors, I just told you that now. In fact, just one other comment. You talked about paperwork and the 40,000 pages of law. Hardly a day goes by in my practice that I don't get so much volume of mail from the insurance companies. So it's ironic to hear you talk about the paperwork load when you dish it out.
Actually, I'm glad you brought that up, because you're...
Would you summarize the question?
Oh, summarize the question?
Was there a question? I think you made it.
Okay, the administrative costs of private insurance are exorbitant compared to, say, for example, the 28% admin cost, which is typically the individual market, not the group market, and I'll explain why. And Medicare at 1.5% as a comparison point. The shifting of funds available to train more in residency programs in primary care, which are available, and like I said, I don't think that everything in VPAC is bad, but lump sum. When I look at what the expectation is, March 24th, the day after, that Monday after this was legislated, by 12 noon, there were 23 calls into the local Blue Cross plan of people asking, how do I get my free health care card? Now, I know no one sitting here had that expectation, but expectations are important. And if we expected costs to go down, the very report that you were citing that was commissioned by Governor Doyle, floating with paper here, Dr. Jonathan Gruber of MIT Department of Economics and the Gorman actuarial firm. The things that came out of that report, which was released in July of last year, 59% of people who buy their own insurance in Wisconsin will experience an average premium increase of 31%. That's more than half, 59%. I don't think that's the expectation. 150,000 people will stop buying health insurance in the private sector and will instead become dependent on the government and taxpayers. Earlier we were talking about free pass. Nothing free. It comes out of one tax pocket or another tax pocket. It's our money. Whether it's a private citizen coming out of my bank account or whether it's coming out of my payroll tax or income tax, you name it. There are a number of expectations, and clearly this was insurance reform. Oddly enough, there's more reports coming that are mandated by BPACA that require the employer and the carrier to provide more reports. Now I want to address the admin because I want to make it clear, I used to work for insurance carriers, so I know how they tick and talk. My business card says R&R, but I would really work for you if you were my client. That's who hires and fires me. So I'm an advocate of people who are looking to buy insurance. Now, you're not going to like what I'm going to say, and it's a dirty little secret of PPAC. When you look at the MLR, the medical loss ratio rule, now there were rebate checks that went out, and among the thousands of pages, I read 346 pages that deal with just that rebate check. Nowhere
Pete, could you clarify that 80, I think you're talking about the 85% rule.
Right.
Could you
this
clarify
is,
for people?
The MLR, thanks. The MLR, there's two ratios. It says if an insurer is in the individual insurance market or the small group market defined as up to 100 employees, every dollar of premium that that insurer collects has to spend at least 80 cents in claims or rebate it or refund it to the policyholder. If it's a large group insurer, and so that some companies